and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Courtney Smith. Today's episode features a discussion on whether patients with HIV should be screened for NAFLD or NASH. This episode is part of a larger educational program titled Don't Forget About the Liver, NASH in Patients with HIV. During this podcast, Dr. Giada Sebastiani from the McGill University Health Center in Canada will discuss why the presence of obesity, metabolic syndrome, persistent elevation of ALT, or exposure to dideoxynucleoside analogues can prompt an evaluation for NAFLD and NASH, particularly in an aging population of patients with HIV. For more information on Dr. Sebastiani, along with CME-certified medical minute models with downloadable slide sets, and clinical thought commentaries from experts, please visit the show notes for this episode. Now let's get started and hear what Dr. Sebastiani has to say on this important topic.
More than 50% of people with HIV in the United States are now 50 years of age or older. Despite improved life expectancy and decrease in mortality related to HIV/AIDS, mortality related to liver disease has increased tenfold in the post-antiretroviral era. People with HIV are at high risk for non-alcoholic fatty liver disease, defined as a liver fat accumulation exceeding 5% of hepatocytes, in the absence of other causes of liver disease, such as excessive alcohol consumption and viral hepatitis. NAFLD is actually an umbrella term encompassing two pathologic and clinical entities: non-alcoholic fatty liver or simple liver steatosis without hepatocytes injury, and non-alcoholic steatohepatitis or NASH, characterized by liver steatosis with hepatocyte injury, inflammation, ballooning injury, Mallory-Yellin, or necrosis. NASH is a progressive liver disease eventually leading to liver scarring, fibrosis, cirrhosis, and end-stage complications. NAFLD affects approximately 25% of the adult population worldwide and is strongly associated with features of the metabolic syndrome, namely type 2 diabetes, obesity, dyslipidemia, and hypertension. The metabolic risk factors, HIV factors, are those which influence the prevalence of NAFLD in people with HIV. NAFLD prevalence is in fact higher in people with HIV, ranging from 35 to 65%. This increased burden is likely driven by a multifactorial and complex pathogenesis underlying NAFLD in the specific context of HIV infection. Metabolic factors such as obesity, insulin resistance, dyslipidemia, and hypertension are very frequent in people with HIV. Moreover, the progression of liver disease in aging people with HIV is complicated by the additional risk posed by HIV-related factors. These factors include chronic HIV-associated inflammation and persistent immune activation, as mirrored by detectable HIV RNA and low CD4 cell count. Additional HIV-related factors in the pathogenesis of NAFLD included prolonged antiretroviral therapy use and past exposure to some dideoxynucleoside analogues, drugs like didanosine and stavudine, potentially leading to hepatotoxicity and lipodystrophy. The guidelines from the European AIDS Clinical Society also suggest that lipid-neutral antiretroviral therapy regimens should be considered in people with HIV at risk of or with NAFLD. Another antiretroviral therapy-related issue potentially affecting NAFLD is the weight gain related to regimen based on some integrase inhibitors. Of importance, NAFLD is not only more frequent in people with HIV than in the general HIV-infected population, but also more severe. A meta-analysis reported a prevalence of significant liver fibrosis at 22% in people with HIV, at least twice that in the general population. Longitudinal studies showed a more rapid progression of liver pathology to severe hepatic steatosis in people with HIV compared with people with HIV co-infected with hepatitis C virus. NAFLD in people with HIV is also a significant predictor of frailty and cardiometabolic conditions such as hypertension and type 2 diabetes. So who is at risk specifically of people with HIV? Given the prevalence and consequences of NAFLD, in which of our people with HIV should we look for NAFLD and how can we identify it? The diagnosis of NAFLD is difficult in clinical settings, as up to 80% of patients may have normal liver transaminases. If it is true that most patients with NAFLD have normal liver transaminases, on the other hand, persistent elevated alanine aminotransferase in absence of other causes of liver disease is strongly suggestive of NASH. In the practice of HIV medicine, chronic elevation of liver transaminases is detected in 15 to 20% of people with HIV, and histological studies reported that 65% of these cases have NASH on liver biopsy. However, liver enzymes may not be the whole story. Available studies report that in people with HIV, BMI and glycemic indices are the most common predictors of NAFLD and associated liver fibrosis. In fact, more than 80% of people with HIV with NAFLD have at least metabolic comorbidities or elevated liver transaminases. Accordingly, guidelines from the European AIDS Clinical Society recommend assessing for NAFLD and associated liver fibrosis in all people with HIV with either elevated liver transaminases, obesity, metabolic syndrome, or past exposure to the drugs like dideoxynucleoside and stavudine. The initial diagnostic assessment should be carried out with non-invasive tests, including ultrasound and the simple fibrosis biomarker FIB4, based on liver transaminases and platelet count.
Thank you very much, Dr. Sebastiani, and thank you to the listeners for joining us. As a reminder, to view the full program and to join the discussion, please click on the link in the show notes. As always, thank you for listening.